Thank you, Ryan. Yeah, thanks everyone for coming. This is pretty meaningful for me to be presenting in front of urologists and people who are really familiar with this. So yeah, my presentation today is titled, Do Psychological Treatments Improve the Sexual Health and Intimacy of Couples After Prostate Cancer? This both involves a clinical trial investigation and also a knowledge translation or implementation project. And it's basically the 2 years of my master's summarized into a presentation. And then I work with UBC Sexual Health Lab, and my supervisor is Dr. Lori Brotto, who's also here today. But we work a lot with Dr. Flanagan, and he's been very supportive in this project. So my learning objectives today are first to kind of share the information or the background on the sexual, relational, and psychological impact of prostate cancer treatments on the couple. And then to explain how sexual education combined with either cognitive behavioral therapy or mindfulness interventions can improve sexual outcomes for this couple. And then to briefly describe the creation of patient education tools that we collaboratively created with the Prostate Cancer Supportive Care Program. And just to give you an idea of what those tools look like and explain a little bit about what went into creating them. So as most of you may know, prostate cancer is very common. So it's around 1 in 9 Canadian men will be diagnosed in their lifetime. And then at the end of 2021, it was estimated that this would be around 3,600 British Columbians. And there's quite a high survival rate. So there's a 93% survival rate in Canada, but unfortunately, prostate cancer treatments can leave the survivors with a high burden of side effects. So when you think about it, there's a very high incidence of disease, unfortunately, very high survival rate, but also a high amount of side effects. So you have lots of people who are requiring supportive care. And sexual dysfunction has been reported to be the most common and also the most distressing side effect for prostate cancer treatments, at least reported by the survivors. And so there's a really fantastic study that looked at kind of 3-year erectile function rates and sexual function rates in 2,500 prostate cancer survivors in the United States. So it looked at them before their treatments and then 1, 2, and 3 years post-treatment. And probably one of their most impactful findings is that of the men who were able to maintain erection before their treatments, only around less than half were able to maintain erections 3 years after their radical prostatectomy treatments, a little more than half after EBRT, so the radiation, and even 75%, only 75% were able to maintain erections when they were undergoing no treatments at all. So this is 3 years of just only undergoing active surveillance. So there is something going on in terms of the sexual dysfunction. Unfortunately, though, medical aids are very successful at treating this. So first line of defense can be drugs like Viagra or Cialis or Levitra, which are not very successful in this population. It really depends on the person who's taking them and the level of tissue damage that they have or nerve damage. But second-line treatments of vacuum erection devices and penile injections or intracavernosal injections can be quite successful in this population with very high success rates, like over 90%. One of the big issues, though, is that survivors aren't necessarily using these erectile aids. So one study looked at a year-long use of erectile aids, and although they found really high success in their use, they found a really low amount of adherence. Around 86% of participants stopped using their sexual aids altogether. So there's something going on then other than the actual medical success of this. So when we look into kind of the qualitative data that looks into why these survivors are not using their sexual aids, there's things that come up like discomfort and pain with use or the feeling of being unnatural. But one of the biggest themes is that there's this loss of spontaneity of sex in their use, and that almost the motivation to using these sexual aids is not really there. So yeah, there's more going on than just the medical treatment. So long-term prostate cancer patients have higher depression scores than the general population. And these depression scores were worse when they were reported with lower sexual satisfaction. There's also been direct correlates in this population found with their rates of sexual dysfunction, directly correlating to lower mood or lower quality of life. And one of the biggest themes that really comes out of the research when we are interviewing those who have undergone some sort of prostate cancer treatment is that sexual dysfunction is never purely mechanical for them. Prostate cancer patients who were interviewed discussed that their relationships or their sexual dysfunction impacted their mood, their relationships, their sense of self-esteem. There's this really big concept of masculine self-identity and masculine self-esteem that's impacted in this population and that has been contributed to this low mood. And this is just a really nice quote that I like that was pulled from one of these qualitative papers. And it was a survivor talking about their experiences with their erectile dysfunction. They said, there is an overfixation on erectile dysfunction because you're not a dog, you're a person. What you actually stop feeling is you stop feeling sexy. What you want physically from someone changes, so you don't have to have that kind of sexual feeling that is linked to getting an erection, but the erection isn't the be all and end all. Yeah, so I think the really big impactful message here is that we have very successful tools to treat this medical problem. But there's almost as if there's an additional aspect to that is psychological, that this population would benefit having some sort of therapy or some sort of way to treat that. Prostate cancer is also considered a couples disease in both clinical care and in both the research because it really impacts both the partner and the prostate cancer survivor. Female partners report high levels of depression, anxiety, and distress, and they report worse sexual function and satisfaction compared to a cancer-free population. And the sexual functioning of partners has been found repeatedly to be correlated with the sexual functioning of their survivors. So when either has worse sexual function, the other one will correspondingly have worse sexual function. And then in this population, qualitative studies find that women also play crucial roles in supporting their partners. So they often organize doctor's appointments, do their own research into the disease. There's also been a big role of women in attending and facilitating group support meetings. And then when we look at more recent studies that have also started interviewing gay men and gay partners, they found similar patterns in these couples, is that the sexual dysfunction really impacts both members of the couple. So what we learned from this is that research, when examining this population, and even clinical care, should really involve examining couples when there is a couple. So what is needed? So based on all this information, we found kind of two needs. One is that there aren't really any established evidence-based therapies that have been tested in this population to really deal with the emotional aspect to sexual dysfunction. And then also that these therapies have not been, they don't really exist in a clinical space outside of general counseling or sexual education. There have been some clinical trials, mostly these were small pilot trials or short interventions that have looked at different ways to target the psychological components to sexual function in this population. So far, the literature just hasn't been very big. So most of these are very heterogeneous in their methodology. So like one clinical trial looked at long-term phone calls with the nurse, which is not very standardized. Another trial looked at a one-day workshop. And most of these, again, have been really small pilot trials. So we're just not there yet in terms of looking at psychological therapies. However, we do learn a lot of lessons from these. And the lessons that we've learned is that when we're looking in this population, it's good to use established evidence-based therapies that have been tested in other populations for the, again, the emotional side to sexual function. It's also really good to involve partners in care and therapy. Usually outcomes are better when they're involved. And that a peer supportive environment or a group environment is really helpful in this population. And so our lab decided to partner with Vancouver's General's Prostate Cancer Supportive Care Program to test two therapies. These therapies have been found to improve the sexual health with women, especially in our research, with women with sexual dysfunction. It's particularly helped women who've had gynecological cancer. And these therapies are cognitive behavioral therapy, or I'll be referring to it a lot as CBT, or mindfulness therapy. And so, the first thing we're going to do is test these therapies in a population at the research and clinical level. So this was the clinical trial. So this began in around 2017, and then we started collecting data and undergoing interventions in 2018. And then a large part of my master's has been coming on and working with and analyzing this data. So it's called Innovations in the Treatment of Sexual Dysfunction and Couple Intimacy After Prostate Cancer, a randomized clinical trial of mindfulness and cognitive behavioral therapy versus a control group. And for short, this was titled the Introspect Study. And the goals of the study were to help improve the overall intimacy and sexual relationship of couples after prostate cancer by addressing those psychological and really relational aspects to sexual dysfunction. And the second goal was to evaluate the effectiveness in CBT and mindfulness in this totally novel population. So cognitive behavioral therapy is a type of psychological treatment that focuses on identifying and challenging negative thoughts and behaviors. In terms of sexual intimacy, this is beneficial in two ways. One, because it reduces stress, which can inhibit our sexual response. But the biggest benefit of CBT is it really prevents individuals from getting caught up in distracting and often upsetting thoughts during intimacy, which can, of course, defeat and ruin intimacy. But it's also quite common to have these thoughts when you have situations of erectile dysfunction or you have to use erectile aids. Men have reported that they can really get in their heads. Several studies have also found that CBT has helped men with prostate cancer, so it's improved their self-esteem and their that concept of masculine self-identity after cancer. It's also found to have improved anxiety and stress, not in prostate cancer survivors, but actually in their family caregivers. And it's also found to help with some unique symptoms after prostate cancer. So it's helped survivors who experience hot flashes after their treatments to cope with them. And then 2 pilot studies in the past have also looked at how cognitive behavioral therapy and sexual health education has helped prostate cancer survivors. So one of these studies found improvements in sexual satisfaction directly after therapy. Another study actually found long-term improvements in sexual satisfaction, which is great. It's just that neither so far have evaluated these therapies against a non-treatment control group. Mindfulness, on the other hand, means intentionally bringing awareness to your thoughts, your feelings, your bodily sensations without placing any judgment on them, like what they mean or should be. And again, this can be useful for sexual intimacy, one, because it reduces stress, but also because it allows people to be very present in their intimate experiences. And then when these negative thoughts arise, they can let the thoughts pass by and bring their attention back to the moment with their partner. Past studies have looked at mindfulness in prostate cancer couples and have found that, or in prostate cancer survivors, and found that it has helped improve mood and quality of life in this population. It's also helped them improve their immune response. It's also been found to help prostate cancer survivors maintain their healthy diets if they practice mindfulness in conjunction with eating and dietary goals. And then unlike CBT, no one in the past has examined mindfulness for sexual health in this population. So prior to this study, our lab actually conducted a small pilot trial of 14 couples to see if mindfulness practice would improve sexual outcomes. And we found that there was some pretty moderate effect sizes of sexual satisfaction improvement long-term, so 6 months after intervention. So given these benefits or these preliminary findings with both mindfulness and CBT for improving sexual function or sexual satisfaction in this population, we began to test it against in a bigger sample with a control group. So we had 4 hypotheses. The first was that sexual distress, relationship satisfaction, and then survivor satisfaction specifically, which has been tested we used the International Index of Erectile Function, and we used their overall sexual satisfaction domain because this has been looked at in a lot of different trials, like those pilot trials have all examined that domain. So we looked at it specifically for survivors as a primary outcome. For secondary outcomes, we looked at whether quality of life, psychological symptoms, so anxiety and depression, and trait mindfulness would improve following the intervention. We also looked at exploratory measures of sexual activity and sexual function. And then finally, we tested for moderators on treatment outcomes. So these moderators were homework practice, their pre-treatment expectations of the intervention, as well as their personality factors. And so, yeah, we did our trials. So we had couples who were completed baseline measures of these different hypotheses, and then they were randomized to either CBT, mindfulness, or a control group. And this is where they attended 4 weeks of either therapy. So they were required to come into VGH, to our lab, for 2 hours each week as a couple, and sit in a almost a support group setting with other couples. And then the intervention was given by someone who was trained in CBT and mindfulness, and also someone who was trained in sex research and psycho-oncology. Yes, and then within those 4 weeks, they were also required to practice daily homework every single night. And then once this was done, they underwent, we assessed them at their hypotheses again 6 weeks after treatment, and then once again 6 months after treatment. So this is what the intervention actually looked like. So we had components of sexual education that were the same in either intervention, and then therapeutic components differed between them. So here's an example of the sexual education that we gave. So I won't go into too much detail, but the goal was to teach participants that there are several reasons to have sex. So this is called the sexual response cycle, and it teaches participants that there are several reasons to have sex that don't normally start with simply having desire, and that desire and arousal can come into the cycle at different times. And so the idea is to really try and get our participants to broaden their definitions of sex and intimacy, and to consider sex as more than a spontaneous activity. And so they had some other sexual education, but this was probably one of the first things we started them with. And it's really trying to get them to move away from that idea of spontaneous sex and to have more pragmatic sexual goals. We also had some aspects of sexual communication. And then we also instructed couples to participate in sensate focus. So this is a touching exercise where couples touch each other's bodies in different stages, focusing on positive sensations, but they don't actually progress to sexual intimacy after this exercise. And the goal is to really get couples to get comfortable with each other, to understand what feels good, and to build intimacy without having that pressure of having to have sex afterwards. For cognitive behavioral therapy, our goal was to get couples to really break down their thoughts and their thought patterns. So to learn what types of negative thought patterns actually occur, what they are, to learn how to recognize them and identify them when they come about, and then to learn how to challenge them and actually actively stop those thought patterns. And this, in this intervention, we applied a lot of these to intimate situations. On the other hand, the mindfulness participants practiced meditation each session, and then they learned a new meditation every week. And the goal was to really train their brain to stay in the present. So they were required to practice 30 minutes of formal mindfulness meditation each day on top of that. And these were body scan meditations. So they were required to, most participants practice them like every night before bed. And the goal was to just get their brain to really focus on that present moment awareness. And then CBT, on the other hand, for practice, participants had to take home worksheets about those thought challenging activities, and they were required to do them each night. So this is the data analysis method that we use. It's called multi-level modeling. I like to include this slide because this is what I spent the majority of my master's doing. So we used a form of data analysis called multi-level modeling, and it's a very sophisticated and precise form of data analysis, and it allows us to account for the interdependence within dyads. And so basically, if we don't account, and dyads being a couple, so the partner and survivor, if you don't account for how their variance is distributed within these groups, then it can really bias the outcomes. Or other studies in the past have just examine partner and survivor separately, which then you're losing a lot of that really rich between couple variance. So what we did is we nested the repeated measures that we took within the person, so the partner survivor, and then we nested their variance within their respective dyad. And this also allows us to examine these couples together without really biasing our results. It also, the multi-level modeling software that we used, it allows us to include all information, so we weren't losing a large chunk of missing data, because a lot of other data analysis methods will do list-wise deletion. And it's just a really great software. So what we did is we tested for interactions of whether or not they were a survivor or partner with their group and time interactions. So we wanted to see if their partner or survivor status affected their outcomes. And then we tested for group by time interactions. So we compared treatment groups to the control group, and also whether they were changing pre or post intervention. And then we also looked at these group by time interactions, and we tested them with any interactions with the moderators. Okay, so on average, our participant was white, well-educated, and an average of 65 years old. Almost all couples were either married or common law, so around 93% were actually married or common law, and they had been together for an average of 28 years. We had 3 gay couples in our study, and then we also had 1 survivor who identified as non-binary. And then in terms of their prostate cancer treatments, so the majority of people in our study underwent radical prostatectomy. We also had a good amount who were undergoing electrobeam radiotherapy or androgen deprivation therapy. A lot of people were undergoing multiple different treatments or had, so they're just all listed here. We also had 9 participants who were still ongoing treatment, and this was included 1 participant who was undergoing chemotherapy, and then people who were either going under radiotherapy or androgen deprivation therapy. And then we also included 4 participants who underwent active surveillance only. And these are our results. So the first thing we looked at was our primary outcome of sexual distress. We used the female sexual distress scale, the revised version, and this is applicable to all genders. It has gender neutral wording. So we applied it to the couples as a whole. So both survivors and partners answered this measure. And what we found is that after CBT and after mindfulness, there was decreases in sexual distress, which is a good thing. They have less sexual distress at the 6-week follow-up. And then this was also maintained at the 6-month follow-up. And this was compared to a control group who had actually an increase or like a small increase in sexual distress over time. We looked at the survivor's overall satisfaction with the IEF overall satisfaction domain. And we found that, again, for both the CBT and mindfulness, sexual satisfaction improved. So it actually increased from their baseline to 6 weeks post-intervention. And this was compared to a control group who had little to no changes or even a slight decrease in their sexual satisfaction. Unfortunately, however, this wasn't maintained at the 6-month follow-up. We expected to see increases in relationship satisfaction just because their sexual function was increasing, and that's been correlated with relationship satisfaction. However, we actually saw decreases in our whole sample in terms of relationship satisfaction. And then when we looked at these time by group, by role interactions, we found that partners were decreasing in their relationship satisfaction after both mindfulness and after both CBT at the 6-month follow-up. And this was compared to little to no change or even an increase in their partners, and little to no change and actually a great increase in the control group for partners. So it's quite a subtle change, but you can see the spotted lines or the spotted lines are decreasing for both the green and the blue, and that's that decrease for partners related relationship satisfaction. We also found that a decrease in relationship satisfaction was affected by the covariate of time since treatment. So as participants were further away from their treatment, their prostate cancer treatments, they tended to have an actual decrease in relationship satisfaction. This has been supported by the literature, is that there tends to be a decrease in relationship satisfaction about 1 to 2 years post prostate cancer treatments. And when we controlled for this, there was actually, this effect became non-significant. However, we decided to still keep it in and graph it because even when controlling from this time since treatment, the effect sizes were still quite large. Treatment expectations and homework practice did not moderate primary outcomes. The moderators didn't really show. I'll discuss that after, sorry. But we found no effects of anxiety and no changes in depression and no changes in trait mindfulness. However, we did find some improvements in different domains of quality of life. So we found specifically for survivors that they had increases in both their physical quality of life after CBT, 6 months post-treatment, and increases in their psychological quality of life after mindfulness 6 months post-treatment. And this was compared to their partners and both a control group who had either decreases or no changes at all in these domains of quality of life. We also found that there was an overall increase in the mindfulness group in their general quality of life 6 weeks after treatment, but this wasn't sustained 6 months after treatment. As well, for this mindfulness group, we found a marginal increase in environmental quality of life. And the effect sizes here were quite large too. So it seems like there's something about quality of life after these treatments that may be related to sexual satisfaction that particularly impacts prostate cancer survivors. So we found no changes really to sexual function and no changes to sexual activity, because we measured both penetrative and non-penetrative sexual activities. However, we did find that penetrative sexual activities actually decreased over time over the whole sample. However, there was a marginal increase for the CBT group at 6 weeks post-treatment. So I just thought this was interesting to note, is that we are having improvements in sexual satisfaction and sexual distress, even though penetrative sexual activities are actually trending downwards. So yeah, again, there's no changes in sexual function. There was no changes in sexual function for both the survivor and the partner, as well as no changes in the non-penetrative sexual activities that they were engaging in. There was also no impact of moderators. I meant to mention that here, of homework practice, treatment expectations, and personality on the primary outcomes. We found some impacts of personality on outcomes, but these were deemed non-significant when we corrected for the false discovery rate. So when we corrected for the odds of discovering a positive test when we had so many different tests. We also conducted a total of 19 exit interviews after our trial had ended. So we had 12 couples participate from the mindfulness group in the interviews, and also 5 couples participate in the CBT group. And then an additional solo survivor in both groups participated in these interviews. And the goal of this was to have a larger qualitative analysis to see what was meaningful, what helped participants, what didn't help them. And for the sake of this, we looked at personal impact questions as a measure of clinical significance. So we wanted to see if participants felt that this trial was actually meaningful to them and to their sexual intimacy. And what we found is that participants in the mindfulness arm had a greater belief in their treatment compared to those in the CBT arm, which is notable because both had improvements. We found that 2/3 of the mindfulness participants said that the intervention had a positive personal and a positive intimate impact on them post-study. But 2/3 of the CBT participants, on the other hand, felt no impact after the trial had ended. And then there's also this kind of repeated theme coming up in all interview groups, regardless of treatment, that there was a real benefit to having partners involved and open to participating in the study. Another thing that came up when I was looking at these interviews was that participants kind of dropped off in their engagement in both CBT and mindfulness and their practices once the trial had ended, which is good because we're still seeing positive effects long term, even though they're not directly practicing. But there was kind of a desire for participants to practice this once again, to have someone that could help them practice these therapies, or one survivor told me to help them hold them accountable to doing this work. So they'd really like some sort of way to stay engaged in the therapies long term. So here are the general takeaways. Sexual distress and satisfaction were improved in this population after both CBT and after mindfulness. And it's quite notable that these improvements occurred despite no changes in sexual function. So their sexual function remained totally the same, yet they were still able to improve the psychological components to their sexual health. And this could be particularly useful for a population where sexual dysfunction is as a result of either their treatments or as a result of their disease. And this could be a really great addition to medical care because we have such effective medical aids for the erectile component to sexual function. So adding in some psychosocial components can be really beneficial. Surprisingly, relationship satisfaction decreased, particularly for partners. Other interventions have found improvements in relationship outcomes when focusing on like couples relationship interventions. And one intervention that's coming to mind, they looked at kind of communication around cancer and also fostering mutual support and understanding within the couple. We didn't have so many aspects of communication or really couples-based work. Our work was mostly focused on the sexual and intimate aspects of relationship. So it might be advised that clinicians in the future may want to combine more communication or relationship therapy techniques for couples, particularly when couples have a need for this. We found varying improvements in quality of life after both CBT and mindfulness. So interventions examining non-sexual outcomes in PCA survivors have found benefits to quality of life. The pilot trials that I've discussed before this intervention have actually found no changes to quality of life. So it's really, I think it's impactful that we found them. So it's likely that CBT and mindfulness provide secondary benefits to quality of life, particularly for prostate cancer survivors. Okay, so we kind of tackled our first need then, in that we were able to test these therapies and provide some established evidence-based work in this population for survivors and clinicians to go off of. But now we have this second need, is that these therapies still need to be applied to clinical care. And so this is the second project that we worked on. So we worked collaboratively with the Prostate Cancer Supportive Care Program, and we applied to Vancouver Coastal Health's Knowledge Translation Grant. And we obtained a grant. We also, through this grant, attended a couple workshops that taught us about knowledge translation and implementation. And we created this study, or rather this project, a mixed methods approach of sharing knowledge of psychological therapies for the psychosexual health of prostate cancer survivors and their patients in British Columbia, or specifically in the Prostate Cancer Supportive Care Program. And so knowledge translation is important because it is this like kind of new field in healthcare and healthcare research where evidence is put into practice, but in a way that's informed by frameworks, informed by knowledge, and that has a really systematic and strategic approach. So CIHR defines knowledge translation as a dynamic and iterative process that includes synthesis, dissemination, exchange, and ethically sound application of knowledge to improve the health of Canadians, because knowledge translation is a Canadian-specific term, to provide more effective health services and products, and to strengthen the healthcare system. And so we really wanted to share this information because there is this kind of urgent need for it. And along with that, it's a lot to expect clinicians to go out of their way to find new ways to help their patients or new studies. It's hard for them to be made aware of this information. So, and then to do all the additional work on top of that of implementing it in their practice. So our goal was to utilize the PCSC to disseminate this mindfulness and the CBT information to prostate cancer patients in the program. We also had additional goals of evaluating this, but for now, we really focused on the implementation. So the Prostate Cancer Supportive Care Program, or I just refer to it as the PCSC, is a clinic located at DHCC on the 6th floor. They see prostate cancer survivors at all stages, so before treatment as well as well into their survivorship. I was talking to a patient who was years into their survivorship and still going to the clinic. And one of the most commonly used they formulated their program around different modules, but the most common one is the sexual rehabilitation module. It was the most accessed by patients, and it teaches them basically, again, how to rehabilitate their sexual function after cancer. And the second most common access resource in this module were psychosocial. This was based on a retrospective analysis they did of their administrative data. And that a large amount of patients were recommended sexual education, like pleasure focus. The PCSC has also shifted to an online format during the pandemic. And they just have a plethora of online education and online information for patients. And so we decided to share this information, and in doing so, we engage different types of knowledge. And I think this is probably, if I could tell you anything, it's that you can get knowledge from different sources when doing implementation. So we had knowledge from our clinical trial, but we also went and utilized knowledge translation frameworks. And we also utilized knowledge translation literature and research to kind of know what we were getting into. And then we engaged forms of knowledge in the form of what people had to offer us. So we worked collaboratively with the PCSC clinical leaders to create this project. We also conducted a focus group of the PCSC staff to help inform us of what was really needed. And then I also met repeatedly with prostate cancer survivor and partner couples, and they really talked to me about their needs in treatment, their kind of thoughts on mindfulness and CBT, and they also helped me look at the different tools I was creating and, told me what they liked or didn't like. So they helped me tailor this to their population. And we had some takeaways from this. These are the main takeaways that we took from all these different forms of knowledge is one, to implement some type of tool or project using the existing infrastructure in the program. To consider patients' individual needs by having the sexual health nurse in the program really help mitigate any barriers or any personal impacts of patients by sharing this information directly with patients. And then we also found that CBT and mindfulness were useful at all stages of the cancer journey, so we wanted to create a way for all patients to access this. And so I'll give you my tools in a second, but we created an information card, and then we also created a page on our online website that taught survivors how to practice these therapies, and also provided them resources to do so. And I'll open that up in a second, but I'm just going to share the process of doing so. So what would happen is that we'd have a sexual health nurse in the program. She will recommend these tools to patients, who will then be able to access them at their home, and then they can choose whether or not they want to go on and actually try CBT and mindfulness. And so I'll just stop sharing. One second. And I'll show you what these tools look like. So we created this. I know it's taking up. So we created a note card that was supposed to be given out to patients and that is currently being given out to patients. And it basically introduces what CBT is and what mindfulness is. And then it gives survivors or couples the option to advance onto the webpage. And if they choose to do so, it will bring them to a webpage we created on the website. And this has a video. It's me in the video. And I talk about prostate cancer. I talk about CBT and mindfulness. And I talk about how to practice these therapies at home. And then it also consists of a blog. And in this blog, it has ways to practice and different links to external websites that are pre-existing that teaches them how to practice these therapies. Yeah, so I'll just finish my slides. But that's what we created. We're in the process of evaluating it. And some key takeaways that are, if you want to implement evidence into practice, knowledge translation and research partnerness can help us move more evidence into practice. Virtual formats are useful for quick dissemination. And UBC and the Vancouver Health Authorities have so many available resources to help you do so. Like, we created our video totally free on UBC Studios. And there were so many free workshops and education sessions on knowledge translation that we were able to attend. Yeah, so that's my presentation. Thank you everyone for listening. If you want to access any of our resources in the lab, you can go to our lab website and also our social media handles. You can also access the Prostate Cancer Supportive Care Program. And I think they have a Facebook page as well. So yeah, thank you.